Yeah, highly undertreated, highly underdiagnosed. One of those.
Okay, so if it's diagnosed, if we know it's there, what kind of treatment are we looking at typically? This is Generation Health. Every week we bring you the latest in news, cutting-edge research, and time-tested best practices, helping you live a longer, better life. Sitting across from me, Joey DiMatteo, PharmD, board-certified clinical nutritionist. How are you, my friend?
Very good. How are you, Tyler?
I'm good. And to my right, Dante DiMatteo, also PharmD, but a certified strength and conditioning specialist. How are you?
Doing well, thank you.
Back behind third mic, we got, or your fourth mic now. Been
I'll
demoted.
take the upgrade to third mic.
You're
All
demoted.
Right.
Your
All
fourth mic.
Fourth mic.
It's on the channel. I know because I plugged it in.
It is.
Unless
yes.
you swapped it.
No.
Josiah Schweinberg, our engineer. How are you, my friend?
Doing well. I have this heavenly
You
glow
do.
right here on the side of my face.
That's good. That's appropriate.
Yeah. And if you're listening, you're missing out.
You're missing out. You're missing out. My name is Tyler Andrews. I'm the host, but that doesn't mean I know what we're talking about. What are we talking about, guys?
We are going to be talking about osteoporosis
Okay.
and some key interventions that you can do to help prevent it and treat it.
Excellent. Excellent. First, let me give you a little bit of news of what's going on behind the counter. There is a fun new study, not fun, this is a fascinating new study, published in the Journal of American Heart Association, has revealed a concerning link between coronary heart disease and dementia. Adults diagnosed with this heart condition, especially before the age of 45, appear to have a significantly increased risk of developing dementia later in life, including Alzheimer's disease and vascular dementia. The study analyzed data from over 432,000 individuals and found that those with coronary heart disease had a 35% higher risk of dementia on average. The risk climbed even higher for early onset cases, those are those diagnosed before 45, with a 78% increase of vascular dementia. Researchers suspect this connection may be due to reduced blood flow to the brain, impacting the cognitive function over time. This study underscores the growing awareness of the complex interplay between heart health and brain health. Early intervention in cardiovascular health is absolutely critical for more than just your heart. Now is the best time to get serious about taking care of your heart and your brain. And that is all we've got for Behind the Counter right now, because we covered so much news in the last episode that we're kind of caught up. That's it. Nothing else happened.
No more news.
No more news. We're done. No, let's talk about osteoporosis. I know that word. I've heard that in lots of commercials. Osteoporosis, what is it?
Osteoporosis is a bone disease that develops when bone mineral density and bone mass decrease, or also when the structure and strength of bone changes. So ultimately, what does that mean? It can lead to an increased risk of fractures.
Okay. All right. So it's thinner bones, less dense bones.
Yes.
Okay.
Yeah, and it's a silent disease, so you really don't know you have symptoms until you break
there's
a bone.
a problem.
Yeah,
Yeah.
or obviously get screened for it. But yeah, that's really whenever you would notice a quote unquote symptom.
Okay. So why does it happen? I mean, I don't want to maybe if we know why it happens, we can anticipate who should be looking out for this.
Yeah, I think that the most or a very critical part of just understanding how osteoporosis can develop is understanding how the bones work.
Okay.
And what they're doing in your body. So the term is bone remodeling. So I think a key thing to remember, I don't know, maybe going way back for me before I took pharmacy and A&P classes, that you would think bones are pretty static.
Yes.
You know what I mean? They're not, but there's a lifelong process going on of bone remodeling. And that's where interventions come in. That's where hormones come in, all those different things. So I kind of want to start with that.
So your bones are continuing to grow all of the time? Is that just, you're saying remodeling, so they're not getting bigger?
Right. It's not so much about growth. That's why the term is remodeling. So again, it's a lifelong process. Mature bone, so bones that are done growing.
Right.
Some of the tissue is removed from the skeleton, from the bone. That's called bone resorption, resorbing it from the bone into the bloodstream. New bone tissue is formed. Also in this process, that's called ossification.
Okay. So your bone cells are literally replacing themselves constantly.
Yes.
that makes sense. I guess I just didn't think about it in those terms. But
and yes, and it's occurring, obviously, following an injury like a fracture.
Sure.
But it's also occurring during micro damage, just normal activity. It's also occurring due to demands on the body, mechanical loading, any stress that's on the body, on the bones. That's your body's response to it. Dante will go into that in a lot more depth, I'm sure, but that's really it's your body's response to changes.
Okay, so if that's how it's supposed to work, what happens in osteoporosis? I assume that process is interrupted somehow.
Yeah. And just to kind of wrap up, in adults, 10% of remodeling, 10% of the bone is remodeled every year. Well, osteoporosis is a result of an imbalance in those two processes. So you've got bone resorption, bone formation. Osteoporosis, again, is a result of that, an imbalance in those two processes. And again, because the body is in multiple different areas is trying to maintain homeostasis.
Right.
It's essentially just trying to an internal state of balance related to its own system. So bones are trying to do that as well, not just like I mentioned with more physical stimuli, but also related to calcium levels.
Okay.
All right. So again, just to kind of back up a little bit, we've got osteoblasts. Those are the cells that secrete the new bone. Osteoclasts break it down. So blast or increasing, class or decreasing is the most simple way to put it. It involves hormones like estrogen, parathyroid hormone, vitamin D, growth hormone, steroids, all those things, also some immune cells. And related to the calcium, so again, bone remodeling is not just occurring during damage of a bone or stress on the bone. There is response to calcium blood levels.
Okay.
And just again, a quick recap, calcium's involved in muscle movement of blood through blood vessels, nerve conduction, hormone release, clotting, heart rhythms, all those things. So when the body, for whatever reason, is low in calcium, that's part of its quote unquote reservoir that it can access the calcium from the bone.
Oh, wow. Okay. That makes sense. So it literally pulls that. I know when I give platelets, sometimes it messes with your blood calcium levels because of the process, and they give you Tums because your jaw starts to hurt somehow. And so the Tums cut that out. Is that I assume that's the same thing?
It's a similar, going on there. Yeah, absolutely.
They're taking a lot of blood from you, I guess.
Well, no, I know it's something to do with an anticoagulant that they use to make sure that you don't stop up while they're doing the process. But I think it pulls from your jaw first, is where it first pulls that out, is what I heard.
Interesting.
I don't know.
We'd have to confirm that.
Yeah, that's what a phlebotomist said. Okay,
I'm sure they know. I mean, I would trust them. They know. I'm sure they know quite a bit about blood.
All I know is the Tums makes it feel better. So
interesting. Yeah, that's what it wants to be.
But yeah, I think that's a good point, if I may.
Yeah.
Is that we talk a lot about hormones and different feedback mechanisms found in the body. We've talked a lot about, male sex hormones, female hormones, and how it's not just this process with hormones that's occurring in a vacuum. It's very much a system-wide, system-wide thing that's going on. And so, you look at somebody who has maybe hyperparathyroid, that sets off a cascade of, increased calcium in the blood. And, that would be something, for example, that you'd look at when, when you're ultimately evaluating somebody who might be osteopenic or osteoporosis. But the point is that there's this whole feedback mechanism that allows the body to pull calcium from the bone, like Joey referred to as a reservoir.
Yeah.
To contribute to the other important functions.
Yeah, to keep you alive until you can store it back up again.
And then, of course, ultimately, the status of your bones pay a price for flaws in that mechanism.
Makes sense. And it's a delicate balance. There's a whole lot going on there, and when you mess with one portion of it, it can affect all kinds of things downstream. That it's hard to anticipate how much and to what degree.
Yeah. And we'll get into it, but even just looking at osteopenia and osteoporosis, it's more than even just the, as I'm sure Joey's going to get to, it's more than just the calcium.
Yeah.
You know what I mean? There are many things that go, it's a bone disease. So if you think about that, at the outset, it's more than just the, decalcification. There's things that happen to the microarchitecture. There are different parts of the bone that have more ultimate, downstream effects from this. So
fair enough. Okay. So why does it happen? Why do some people have brittler bones, have osteoporosis over time? Why would that change?
Yeah, there's a lot of levels to that, but just kind of at base, it can occur at any age. Okay. The risk, though, of course, increases as you get older.
Okay.
Particularly for many women, this process begins a year or two before menopause, kind of in that perimenopause transition phase to menopause, where you've got irregular periods, lower sex drive, fatigue, hot flashes, those kind of things. Your estrogen levels are decreasing, or at the very least, they're more irregular. And that has an effect on bones, which we'll kind of get to piece by piece here. So related to sex, male, female, your chances of developing osteoporosis are greater if you're a woman. Women have lower peak bone mass and smaller bones than men. So that's, one reason structurally, so to say, why they're affected on top of the hormone issue. Men are still at risk, particularly over age of 70.
Okay.
So body size also, kind of back to that same thought, slender, thin bone women and men are at greater risk to develop osteoporosis compared to larger bone. Race plays a factor as well. White and Asian women are at the highest risk.
Okay.
African-American and Mexican American women have a lower risk. And then as far as men go, white men are at a higher risk than African-American or Mexican-American men.
Wow. Okay. So it sounds like there's a whole bunch of, this can affect anybody, but it sounds like there's a whole bunch of risk factors and they kind of pile on for some people.
Yes.
Okay.
Yeah, including family history as well. History of fractures, as well as osteoporosis diagnosis.
Okay.
Yeah, there's said to be that, genetic factors play a huge role and account to up to 60 to 80% of total adult bone mass. So there are certainly modifiable aspects that we'll talk about, but there's, as Joey said, there's
80% a lot.
There's a heritability component for sure.
Yeah.
Or even just kind of just the hand you're dealt, so to speak.
Yeah.
So,
okay. Anything else that causes it or can affect it?
Yeah. I mean, it's kind of dig a little bit deeper on the changes to hormones, ultimately estrogen. So estrogen levels have decreased dramatically in women after menopause. And also in that perimenopausal period, there's a disorder of an irregularity of estrogen levels. Estrogen. So why ultimately does that matter? It goes back to some of the technical stuff we talked about earlier. Low estrogen levels are associated with increased osteoclast activity. So when your estrogen level is low, you have more of the osteoclasts, which break down bone. So basically, when your estrogen levels are low, you resorb, and there's more bone resorption.
Okay. So you're losing more bone
when
the levels are low. Okay.
Yes. Testosterone has also some association, not to the degree that estrogen does, but testosterone via its conversion to DHT does bind to androgen receptors on bone. Its mechanism is a little different. It can promote the activity of osteoblasts. But it's critical to mention also that there's estrogen activity in men. I know we don't associate that, but there's obviously estrogen activity in men. Estrogen receptors themselves have much higher effect on bone density than androgen receptors.
Okay.
So again, there's interplay there, and estrogen's mainly working on inhibiting the breakdown, and testosterone definitely has some effect on increasing the production. But that's kind of the little more nitty gritty on why that occurs.
One more factor as to why, generally speaking, men tend to have thicker, bigger bones is because of that hormonal interplay that you're talking about.
Yeah. Also in genetics, when you look at all the levels to it, yes, there's the interplay there.
Okay.
Yeah. Right. In osteopenia, osteoporosis is certainly a potential downstream effect in men, with hypogonadism, as we alluded to before, which piggybacks on what Joey's saying, the decrease in testosterone and the decrease of activity at the estrogen receptors in bone as well.
Wow. Okay. Anything else?
Yeah, there's still a few layers here. Diet.
Okay.
Even beginning in childhood, because on one hand, we're saying that there's a lot of bone remodeling occurring, 10% a year, but over time, but we still have 90% that's not remodeling. So even beginning in childhood, just your overall diet that's low in calcium and vitamin D over time does have an increased risk later in life. Excessive dieting, so essentially related a lot to, decreased intake of those things.
Yeah.
And also poor protein intake has been linked to an increased risk of bone loss and osteoporosis.
Fascinating.
And this is where it can get a little complicated. There's obviously medical conditions, various, and endocrine, hormonal diseases,
Sure.
Hypogonadism, like Dante mentioned. We talked about the menopause process, rheumatoid arthritis, HIV, AIDS, cancer, all those things.
Yeah.
We're kind of more talking about a broad approach here, but all of those things, we'd be remiss to not mention that they certainly can be contributing factors.
Okay. All right. And then you said, is there medications were mentioned?
Yes. Medications, namely glucocorticoids. So
Okay.
it's fancy word for what's essentially prednisone, Medrol, those types of things. And the effect is particularly seen when they're taken orally, although definitely have seen that in higher doses, inhaled steroids that are used for asthma or COPD can have an effect as well.
Okay.
And then again, there's more kind of less common medication, anti-epileptics, cancer meds, even SSRIs, and PPIs. Those are commonly used meds, but they have a lower effect.
Okay.
The one that's really moving the needle, in terms of what, potentially, a lot of people are exposed to, or a larger population, would be the glucocorticoids.
Okay. So if you are female and Asian and postmenopausal and on a corticosteroid, this is a very, very relevant conversation for
Exactly.
you. If you're a 23-year-old male who eats tons of vitamin D and calcium-rich foods, then this is probably not as relevant for you. But when you pile on those various risk factors, fascinating. Okay.
Yeah.
All right.
And I think, go ahead.
Sorry, I was just gonna say that's a good way to kind of tie some of that together.
Yeah.
In that, again, when you're diagnosing somebody with osteopenia, osteoporosis, not to jump ahead, there are different calculators that take those, that take all of those sort of risk factors and then assign them some value,
Right.
and determine whether or not maybe they're a candidate for further workup or treatment.
Right.
Because again, yes, we'll talk about DEXA scan and we'll talk about the ways that we can look at bone,
Yeah.
under a microscope basically. But in general, even if some of those numbers when looking specifically at the bone aren't as glaring, certainly want to look at some of the other things that you've mentioned. And
Right.
there are tools that do that already. Because this is a global sort of bone disease.
Right. And risk is not the same thing as actually having it. If you have a 50% risk, that means you have a 50% risk of chance of not having something too. So this is not a black or white issue in that sense, but as you pile these things on, that makes sense. Okay.
Yeah, and to stick with the glucocorticoids just for another moment, because I do think it's important to say, again, I'm in the pharmacy world, so I try to gauge reactions that we receive, and could see somebody saying, well, you know what, I'm at risk for osteoporosis, whatever the case may be, some of the things you mentioned. Oh, my doctor wants to put me on, I'm very sick, or I've got this terrible back nerve issue, and my doctor tried to put me on Medrol or prednisone. I can't take that. When you're talking a few days, that is not what we're talking about. We're talking about, it's defined as well as possible that chronic heavy prednisone use is 2.5 to 5 milligrams over the course of 3 months.
Okay.
So no, we're not talking years, but we're also not talking that 6-day course from your doctor either. So there are certainly needs, to take those medications in certain situations. It's not going to cause some type of, catastrophic bone issue. It's again 3 months. And then also once, those medications are discontinued, including, if need be, high doses of inhaled steroids. The effect does quickly reverse the bone effect. But it's the most glucocorticoids used as the most common cause of osteoporosis before the age of 50.
Okay.
So that's a small cohort, but it's the number one in that cohort.
So it is real
a big deal
for
Yeah.
those people. Do we have any sort of statistical knowledge of how different this is for men and women?
Yeah, in terms of osteoporosis diagnosis, it's 4 times more common in women than in men.
Oh, wow.
One interesting, and again, some of this will go into just, random studies and facts here, but just touching on, yes, osteoporosis and fractures. The prevalence is much higher in women than men, but there was a large study done in patients, men and women, over 50 years old. All-cause mortality is 70% higher in men. And that they even controlled for pre-existing conditions, because that's where my mind went, was that there was other factors here. They controlled for them as well as they could. Couldn't get the exact reason why this occurs, but men have much higher infection rates. So it's a very serious issue related to outcomes in men, even though the prevalence is lower.
Okay, so you said, to make sure I'm understanding this, despite the fact that it's much more common, osteoporosis is much more common in women, when it occurs in men and there's a break, the end result is substantially worse.
When a hip fracture occurs, yes.
Wow.
Over the age of 50, yes.
Okay. And this is why we hear about old people breaking bones when they have a small bump into something or a fall. Is that right? This is what we're talking about here?
Yes.
Okay. So what else is going on there? Is there anything else different that we need to talk about between males and females?
Yeah. So the other issue is just kind of not just the actual diagnosis, but what ultimately results from that. Just a couple examples. So the annual bone loss at the femoral neck, like at the top of the thigh, for men is 0.82% loss per year. Women is 0.96. So that is statistically significant. So in that same study, they did find that for men, the decline occurs most from age 74 to 79, whereas women, it is occurring earlier from 65 to 69 years old.
Wow.
So again, it is critical to understand that this is occurring earlier in women. All sites measured in this study, by Framingham Osteoporosis study, 800 elderly men and women, mean age 74 years old. So they evaluated them over 4 years. The range for bone loss in men was from 0.2, so almost none over those 4 years, even at 74 years old,
wow.
from 0.2 to 3.6% in men. For women, there's just a much tighter window and also a higher ceiling, 3.4% to 4.8% for women. That was the range.
3.4 to
4.8% in women.
So even on the good end, women were losing much more bone mass than
about the same as on the maximum end of
for
men.
men. Wow. That's incredible. And this is primarily a result of the hormones being radically different.
Yes. And then remember this
and
study
having fewer or thinner bones to begin with.
Yes. And this study was done at 74 years old. And remember that in the maximum decline occurs in women from 65 to 69. So when you look at over the course of time, that just shows, a pretty serious, just again, lifelong process that goes on, later in life related to bones.
This is a really big deal. You mentioned the femoral neck. What is that? I guess there are specific places where we measure bone. What is that?
The femoral neck is the top of the femur or the top of the thigh bone.
Okay.
So kind of getting now into the diagnosis, the bone density is measured at certain spots. The lumbar spine and the lower back, the hip, a specific site, which is near the joint, and also the femoral neck, which is the top again of the femur.
Okay.
So that is where bone density is measured.
How is bone density measured?
So bone density is measured via low-level X-rays. The scan, it's called a DEXA scan. That's what you'll hear whenever there's a test. So what that does is it gives you, and it's just for information, they're using 1/10 of the radiation of a standard chest X-ray. So this is not the same level there.
Right.
It essentially gives you a value so that you can assign a number. It gives you a T-score. It's a statistical measure that uses standard deviations and basically gives you a value for how far you are away from the mean or from the average. Okay. And it is based on adults of your sex and race at the age of peak bone mass. So it's not a moving target. Its peak bone mass is achieved, what they're using is 26 to 30 years old. So again, it's measuring the difference, the standard deviation difference, statistical measure from there. So if you're one standard deviation, quote unquote, worse or to the left, you get a negative number, -1 or greater, you're considered normal. And obviously anything in the mean or higher is considered normal bone density. If your T-score falls between -1 and -2.5, you have low bone density, which is termed osteopenia, but you're not yet in the osteoporosis range.
Okay.
It's 2.5 when you're 2.5 standard deviations away from the mean. Even if you haven't broken a bone yet, you'll be diagnosed with osteoporosis.
Wow. Okay. So, and does the bone break, is that like a trigger for a lot of people to get this checked out?
Yeah. Essentially, if you're over 50 and you've had a fracture of these major bones, spine, hip, wrist, shoulder, pelvis, they will obviously follow up with a scan, but it's likely you have osteoporosis given the occurrence.
Man. Okay.
And again, these are a result of non-traumatic forces. I mean, obviously there's to be some impetus, but we're not talking about car wrecks.
Okay.
And, major sports injuries or major accidents.
That makes sense. If I don't want to wait for a car accident or a bone break to trigger that kind of thing, what kind of screening is typically done and when?
So the screening, the DEXA scan is the screen. It's really about when the recommendation is. So all women over 65 years of age are recommended, as well as postmenopausal women with risk factors. So if you're falling maybe a little younger than that, but you've kind of gone through the hormonal changes, it is recommendation you get screened. All men 70 years of age or older, no matter what, but also a much wider range, 50 to 69 years if you have risk factors.
Okay.
So they did a study though, however, that despite these pretty clear-cut recommendations, it was 8,262 patients. They found that only 60% of the women who should have been screened were screened, and not shockingly, a much lower number of men who should have been screened, 18.4% were screened. Again, that's looking at 8,200. And what was key is that they only evaluated in that 8,200 people who have seen their doctor for a routine appointment since they met the criteria.
Wow.
Not, I had a doctor's appointment when I was 28 or 42. Once you crossed over the criteria for screening, you have seen your doctor for a routine appointment. That was the inclusion criteria. So that shows how few, even women to only be at 60% is interesting. Men at 18.4 though.
People need to be aware of this and actually take some action, especially if men have such negative outcomes as a result of breaks from this.
Right.
Wow.
Yeah. Highly undertreated, highly underdiagnosed. One of those.
Okay. So if it's diagnosed, if we know it's there, what kind of treatment are we looking at typically?
So from the medication standpoint, there's two broad classes, one of which much more common. You've got anti-resorptive drugs. So we talked about bone resorption, which is kind of that process of pulling it out. Yes. So it slows down the rate that your body breaks down bone. In terms of commonly used meds, they use the term anabolic. That would be the other class. Is Forteo, that actually increases bone formation. But again, you're typically going to see, and it's not anabolic in that way we typically think of it, muscle building. It's just the most broad definition of just building up.
Okay. So
bisphosphonates are what you're typically going to, if you qualify to be prescribed here. So they work by, again, slowing the rate of bone loss. It's not like actively growing bone. It is decreasing the number of osteoclasts. Literally the number of cells, it's decreasing those. So there's less, there's a slower rate of bone loss. So this is your Fosamax or alendronate, which is a once a week pill, Boniva once a month. It's those types. And now there's also an once a year IV like Reclass. It's those types of medications. They're all in the bisphosphonate class.
So they're slowing down this natural body process. I assume there are consequences for that. These are all delicate systems here. What are the side effects of taking an anti-absorptive?
Yeah, anti-resorptive. Yeah,
resorptive.
So for the pills, nausea, heartburn, stomach pain. It really has a lot to do with just how the pills physically are affecting, as you're ingesting them. You also, especially with the IV ones, you're more likely to get some fever, headache, and muscle aches. Those can last up to 3 days.
Okay.
But it's definitely something that a lot of people are concerned about. Osteonecrosis of the jaw. So this is basically when your jaw doesn't heal after you've had a tooth pulled or something like that. The risk of that really goes up if you've been on the medication for longer than 4 years.
Okay.
And to tie in, typically, what's recommended is if your bone density is steady, you've been on this medication, your bone density has been steady for 5 years, obviously no fractures, then some doctors do essentially have you take a break for a period of time. But again, the osteonecrosis risk really hits at about 4 years, or of course, it's always going to link to the steroid use, the preds, the glucocorticoids, if you've been taking those chronically.
Sure.
And again, the ones to watch out for would be high dose inhaled steroids as well.
Okay.
All right. So yeah, that kind of covers the bisphosphonates. There's also a medication that's more commonly used nowadays. It's every 6-month injection, Prolia. It does also work to prevent the breakdown of bone, but it's not recommended in patients with low calcium levels, just via the mechanism that it works. So you want to make sure you're taking calcium and vitamin D with that one.
Okay.
And also joint and muscle pain, pretty common side effect with that. Evista, or raloxifene. It's a selective, it's called a SERM, a selective estrogen receptor modulator. Basically a fancy way of saying that it has estrogen-like effects and can mimic estrogen. What's unique about it is on certain receptors, it's a estrogen agonist, and in other receptors, it's an estrogen blocker. So for example, in the bones, it functions like an agonist, so it will prevent bone resorption, but also at other receptors like in the breast or uterus, it can be used, it has anti-estrogen activity, so it can be used to reduce risk there.
Oh, okay.
These medications are not as effective for bones and osteoporosis and bone health as bisphosphonates are. And because of its kind of dual estrogen activity, also hot flashes, things like that, can be side effects of it, which a lot of women at this age are already dealing with. So,
don't necessarily want to make
between
that
the
worse.
effectiveness and that, it's not used nearly as much as the bisphosphonates, and rightfully so. In terms of the other class, the anabolic types, again, the bone building, not muscle building, the Forteo is the main one, an injectable drug. You can only use it for 2 years. It is if you have been diagnosed and consistently have low calcium, this is the preferred drug, essentially because it's a mimic of the parathyroid hormone, which can have effects on calcium levels, not just at the bone level, but at kidney and intestine level as well.
Okay.
So it's going to interplay on all those areas. And so or for whatever reason, maybe it's your diet, whatever the case may be, but you have low calcium, this is preferred for you over the other classes.
Okay. You mentioned calcium and vitamin D a couple of times there. What's going on with that? How much of a role does diet play in all of this?
Dietary intake, a general, dietary pattern matters a lot in this context, and specifically looking at calcium and vitamin D, there are some important aspects to consider. So just in general, kind of like we mentioned, sufficient calcium intakes are absolutely necessary for the acquisition of peak bone mass in development. So eating enough calcium, drinking enough calcium in the form of milk, etc., is critical, as actually the skeleton contains 99% of the body's calcium stores. Oh, wow. So again, as soon as you were to, become deficient in what you're consuming, either just by intake or some other health issue, that's where that, again, resorption process comes into play. The blood and other functions in the body need that calcium, and you're pulling it ultimately from the largest reservoir that's found.
And you're just not going to know. It's not like you feel it internally that, oh, now I'm pulling from my bones. It just happens without you thinking about it.
Exactly. And, again, thankfully our body has these feedback mechanisms in place. But yes, this is something that is going on under the hood, under your conscious awareness.
Okay.
So in general, again, I think that just speaks to the importance of diet here. In general, what's recommended is about 1,000 milligrams a day of calcium in those 19 to 70 years old. And in women,
19 to 70.
19 to 70. So
nearly everybody. Okay.
And there might be some varying recommendations depending on the depending on the organization that you're looking at. In general, about 1,000 milligrams a day is recommended in men 19 to 50. Once you are greater than 70 or you're, greater than that cut point, it jumps up to about 1,200 milligrams per day.
Okay.
And then the general recommendation for women is 19 to 70 or 19 and beyond basically is 1,200 milligrams per day.
Okay. So for women, it's just 1,200 all the way through. For men, it's 1,000 until about 50, maybe up to 70. Then it goes up.
Exactly.
Got it.
Exactly. Now we'll talk a little bit about supplemental calcium, but in general, there's some evidence that supplemental intake above 1,200 to 1,500 per day can actually increase the risk for the individual of developing kidney stones in kind of specific at risk. Again, the only reason I mention that is this is not something you just want to be taking 6 big calcium tablets every day.
You can overdo it.
You can overdo it for sure. Again, because of that complex interplay with calcium, the bone, the blood, parathyroid, etc.
Makes sense. So your bones might be thick, but you'll have kidney stones, and that's awful. So
exactly.
Okay.
Especially just a few. This is a lot of the population we've already discussed, but I just want to mention who should supplement.
Yeah,
that is controversial. We don't have all those answers for you, but in terms of who should, with the details again are a little controversial. But glucocorticoid use again, especially oral, but also inhaled, perimenopause, family history. Obviously, if you've been diagnosed with osteopenia. But then the other ones are risk factors: sedentary lifestyle, chronic heavy alcohol use, smoking, even excessive caffeine intake can be, contributing factor.
Wow.
So when you look at, again, when you're evaluating just the overall picture, you check some of these boxes, but no, should a 35-year-old woman with none of these risk factors just start taking calcium because they're worried about, they only check maybe the family history box? No. So it's a combination of all these things.
Okay. All right. Fascinating. All right.
Yeah. And that's a good point. As long as you're staying within the bounds of kind of what's recommended there, you're hard pressed to see any major issues. The one caveat would be just to be mindful of, or maybe start to pay a little more attention to the amounts or the types of foods that you're eating that might be rich in calcium, that'll affect obviously maybe how much you're supplementing with. And that's tricky because not everybody is weighing their servings. Not everything is a nice 8-ounce container of yogurt or an 8-ounce glass of milk. You're eating cheese here and there, or you have a scoop of cottage cheese or whatever. I know that that's difficult, but some of those calcium rich foods are some of the obvious ones that we probably all know from elementary school. Good old milk, almond and soy milk, yogurt, cheese, and of course, fortified foods and juices are going to be rich in, they're fortified with calcium and vitamin D.
Got it.
And then tofu is another actually fairly rich source of calcium. And so in general, if you were to drink an 8-ounce glass of milk, the estimated calcium per serving is 300 milligrams. So right there, if you have a couple glasses of milk, almond milk has even more on average, 450 milligrams.
That's a lot
in
more.
an 8-ounce glass. So not as we allude to when we're talking about calorie counts and, protein amounts and all those sorts of things. Sure. I know it's not an attractive thing to do is, unless you're Tyler, is measure out your every meal. I've never seen someone stick with their dietary tracking quite as long as Tyler, which is impressive. It
can
be done.
Sit next to you. Are you kidding me?
But no, just, as Joey mentioned, there's quite a large list of those who would potentially be candidates for some additional safe supplementation. Just first pay attention to what you're consuming in your diet.
Right.
And if you have more questions about that sort of stuff and, you're unfamiliar with food labels and it's probably it's probably better served as a targeted question.
Sure.
But just pay attention.
Yeah. Okay. So that's calcium. Is there, vitamin D I know is a part of this. How is that different?
Yeah. They're often a tag team duo.
Yeah.
I would say in this context.
Why is that? Just as an aside.
Tag team. What's a famous tag team? Go ahead. I know you got one in it.
The Rockers.
Yeah.
Shawn Michaels and Marty Jannetty.
We've descended to pro wrestling.
Tag team.
Wrestling's just been hot. Old wrestling has been hot on my mind. So,
All right. So which one is, so the Rockers, vitamin D and calcium, tag team. And
Shawn Michaels is the vitamin D. He's a little more controversial.
Clearly. Why?
New supplement line coming. Get it at AskJoeDiMatteo.com.
Oh my
The
gosh.
Rockers.
Why are these two, why are they such a tag team? Why do they go together?
So
Calcium is what builds your bones.
Right.
What does vitamin D do?
we have entire classes, not entire classes, but entire segments of classes on how this feedback process occurs, how parathyroid plays a role, how your kidneys play a role, where the bone comes in. I mean, it's
complex.
It really is.
Okay.
It's fascinating. But for all intents and purposes here, vitamin D is facilitating calcium absorption necessary for mineralizing bone.
Okay. So vitamin D tells the body, hey, absorb this.
Mm-hmm. And so there's even some gray area with, how much is needed to facilitate the absorption. Does everybody need to take vitamin D if they're taking calcium? Some of those questions I'm not super confident in answering, to be honest, but in general, the biggest thing to pay attention to with respect to vitamin D is if you are somebody who has some of these risk factors, or you already know you have osteoporosis, or you've had a history of, non-traumatic fractures and such. I'm sure you've had a vitamin D level drawn, and I'm sure this is, already being addressed, but knowing the baseline level of vitamin D will often dictate, even if you're osteoporotic, that level of vitamin D will dictate whether or not you need to supplement in larger amounts of vitamin D. And so in general, there's depending on where you look, 600 to 800 to 1,000 units of vitamin D is safe, up to 4,000, 5,000, little controversial.
Sure.
But in general, you can take some supplemental vitamin D on a daily basis relatively safely. But knowing that baseline level is going to be critical just as a general recommendation.
So knowing the baseline determines how much and if you even need to be supplementing or considering it.
Yes, because again, just back to kind of the physiology or the pathophysiology, if you are definitely deficient in vitamin D, that could certainly be contributing to the lack of mineralization that's occurring at the level of the bone. So by addressing that can certainly help to, I would say, ramp things up.
So even if you drink, 5 big glasses of milk a day, if you're not getting enough vitamin D, then the calcium is irrelevant.
Exactly.
To some extent. Okay.
Exactly. And there's still lies some, controversy there as well. But again, just sort of the downsides of doing some supplemental D like that is not going to be the end of the world. And ultimately, if you were to look at that case specifically, you would probably end up doing what is almost like these loading doses of vitamin D. Mm-hmm. So you do 50,000 units a week for a certain amount of time, and then they back you to essentially build that reservoir, and then eventually they'll back you down to 1,000 units a day or 2,000 units a day based upon where you sit. But that's a good example. That's probably a pretty classic case.
Makes sense. That's really cool.
And I'm sure Joey might have more to add there as well. I know I alluded to knowing that vitamin D level, and that vitamin D level will depend on the units that you're looking at. As Joey and I discussed, you'll see it in nanomoles per liter. You'll see it in nanograms per liter. And they're similar, generally similar numbers. So it helps to clear that up. So in general, the normal range for 25 hydroxy vitamin D is 20 to 50 nanograms per milliliter. And in, some places will recommend staying above 30 if you're in the situation of osteopenia, osteoporosis. There was one paper that looked at adding additional vitamin D to those who were not osteoporotic or osteopenic. The average level of 25 hydroxy vitamin D in that study was 27, and adding about 2,000 units a day of vitamin D supplementally didn't add a ton of benefit as far as bone health or bone measures, so to speak. So it's very context dependent on the demographic, the level. It's not
if you're
by
already
optimizing your vitamin D level, if it's already close to normal or normal, I don't know how much, again, that's going to do for bone health and bone measures, so to speak.
You or I presumably having healthy bones at this point, not having a bunch of the risk factors for osteoporosis, boosting our 25-OHD level substantially isn't going to necessarily improve our bone health at all because we're already healthy that way, correct?
Yeah, and you might be taking it for other reasons.
Right.
But I think in this context, we can agree there.
Makes sense.
Yeah, and I think too, just kind of back to the controversy of the level.
Yeah.
Because to me, whenever you are taking, in the supplement world, something where the level is measured, proof's kind of in the pudding. If you decide to take 10,000 a day and your level is low normal or normal, okay. It's to me, it's really about the level, as long as you're keeping up on that. And then in terms of the controversy, we know you want to be over 20, right? That's accepted. And then on the other spectrum, excess vitamin D level is defined as over 100.
Oh, wow.
So maybe you read a study or you have a practitioner, they swearing at 50 or 70. You've got to be at 50 or 70. My doctor's okay at 30. Doesn't have to be the controversy that it is because you're not at the upper level.
Right.
Vitamin D intoxication, or actually hypervitaminosis D, is defined over 150.
Wow.
So if you're comfortable with somebody who's recommending you at 50 or 70, I really don't see the downside, given it's still how far you are away from the extreme. So are we giving you an exact answer of this is the new hot level that we recommend? I personally, I guess I'm not doing that, but we know the minimum and we know what's definitely too high. Somewhere in the middle, there's some gray.
Yeah. And I think Dante said it earlier, the proof is in the results.
Yes.
If you're not getting the results you need, you might need more.
Mm-hmm.
Makes sense.
And vitamin D is just you could bring it up in a million different contexts. And in general, for example, the person who's taking 10,000 units a day or 5,000 units a day, and it's kind of barely moving the needle for them. There are many instances where absorption is different or changed or altered in a negative way. So individuals with celiac disease, inflammatory bowel, those who have had bariatric surgery, also just the way that we absorb vitamin D in through the skin from the sun,
right,
changes based upon the demographic, the skin color, the pigmentation. So there's so much there. And then also just the idea that, vitamin D is often maybe reflective of the level, low, high, or whatever, reflective of a relic of other coexisting conditions. So that's the point, I think, of those kind of large ranges.
Makes sense.
It's tough, but you don't just can't sit here and recommend you run to your doctor and demand a vitamin D just out of concern. If you just have general, concerns.
Just because the number is X.
Yes. Yeah.
Don't freak out.
Mm-hmm.
Got it. Any of the products we mentioned, we talked about calcium and vitamin D. Those are available on our website. You should go there and check them out. AskJoeDiMatteo.com. AskJoeDiMatteo.com. You can find past episodes of this show. You can find the show that started all this, the Ask Joe DiMatteo show. All of it's there on the website. If you have a question, email us. That goes to questions@AskJoeDiMatteo.com. That's how we like to hear about those. Show notes, any of the articles, the studies that Dante and Joey referenced, those will all be available down below in the show notes or wherever you're listening in the show notes portion. And if you learn something from this, share it with somebody you know. This affects so many people, especially women, especially as they age. Someone you know certainly needs to hear this information. Go share it with them. That's how you can help us out more than anything else. That has the biggest impact. 5 stars, big thumbs up, anything like that, also helpful. But please share the show, whether it's on Apple Podcasts, Google Podcasts. Oh, that doesn't exist anymore. Apple Podcasts, Spotify, YouTube, Rumble, wherever you listen or watch, share it with a friend. Anything else? So I should thank the people that are involved in this. Josiah Schweinberg, Michael Deppish, our editor, Joyce Gibb, nurse practitioner, who handles private consultations, Diane Silverman, who handles product, Terry, who does scheduling, Cecilia, who does distribution. That's Joey. That's Dante. I'm Tyler Andrews. Thanks so much, guys. We'll see you next time.